And let's go on to our very first speaker, Dr. Padmaja Kumari, who is the most respected vitreoretina consultant in our country and currently heads the tele-ophthalmology unit of the LV Prasad network. And she is going to talk to us on something so quintessential and important. She's going to tell us about the quintessential scleral buckle. So on to you, Dr. Padmaja.
Thank you, Chitramati, for a kind introduction, and it's always pleasure. And thanks, Ashriya, for inviting me to this. And to see my two lovely LVP alumni is really a pleasure, both Ashriya and Srishti. So, are my slides are seen clearly?
Yes, yes.
Yes, ma'am.
So, quintessential scleral buckle. So, I think if we say one surgery in a retina surgeon can do and then sleep peacefully in the night. Probably, if everything gone well, is one of the I would say that scleral buckling, and it is a gold standard as far as concerned with the repair of the primary rhegmatogenous retinal detachment. So when we look at the secret of success story of scleral buckle, I learned the art in Shankar Netralaya and then practiced in LV Prasad and continue to teach. And this is one of the surgeries which I love to teach, and then it should go on for generations because and the secret of success is three aspects, I would say. That is good localization of the retinal break, and then appropriate treatment in the form of retinopexy, which could be cryotherapy if the retina is detached. It could be laser therapy if it is attached retina. Then it is, I always say that the scleral buckling surgery is like a designer surgery where you properly select and place the buckle of appropriate width and length to cover the break. And then the third aspect is, if needed, the subretinal fluid drainage, if it is can be done uncomplicated. And these are the three will be the success of the story of the scleral buckle. So I will share few of the case scenarios where buckling in this scenario with the tips, few case scenario, how a buckle case can be, can be practiced. So for example, this is a case scenario of a 24-year-old one-eyed patient, phakic, and you can see that there is a laser barrage has been done. Ideally, a laser barrage should be done only subclinical RD, that is around 2 disc diameter, but someone has done a significant barrage. But the patient came with he's a one-eyed and he's having a lattice with a hole with a minimal tractional component as well. So this is a case where what we have done is that the most important is the localization of this lesion, the localization of this break in drop from the ora, that is the muscle insertion, and which was around 5 millimeters from the ora. So then we have chosen a buckle which is at least a 7 mm width, that is 2 mm more than the break. So it is 287. I prefer convex buckle whenever I see any tractional component. And you can see very nicely the retina post detachment, post buckle. We have done drainage also, and then the very good settlement of the retinal detachment. So what is the tip here? Location of the primary break is the most important. Convex buckle is preferred whenever you think that there is some tractional component. And posterior laser barrage marks itself is not a contraindication, even though sometimes it can be tricky. But you should always try a buckle first. And if it is only failure only, then you should go for the vitrectomy component. So here we could actually had a very good successful attachment of the retinal detachment. Now, this is another case scenario where again a one-eyed phakic 18-year-old high myope, and you can see that right eye is already spontaneously attached retina, and left eye you are having a retinal detachment inferiorly, and you can see it's a shallow detachment, and could not really see clear-cut breaks. So I chosen a end-to-end, that is these two quadrants, inferior quadrants, 276 style. So we have done suspicious areas which has been cried. Inferiorly, it was quite significant bullous fluid was there, so SRF was drained. And you can see very nicely the patient had a retinal attachment. So the idea is and you can see the OCT also completely nicely in the attachment. So no visible break is also not a contraindication when you know that 18-year-old with a complete vitreous, no vitreous detachment, and you saw that there is a inferior detachment. So end-to-end buckle with the suspicious area also can solve the problem. This is a case where you can see again a phakic. You have multiple holes, and morphology of the hole is again important. Localization, again, we should look at whichever is the posterior break and try to localize, which is around 5 mm from ora, and chosen 287. And you can see that the retina is attached. So multiple breaks again is not a contraindication. Actual localization of posterior margin of the posterior break is the important. This is a scenario of, again, 49-year-old male phakic. You can see a lattice which is there, and localization is 7 mm from ora. Why it is important to localize? Because the localization will help you to determine the adequate width. Here, because it is 7 mm, you need at least a 2 mm additional coverage. So you need a 279 buckle, and you can see very nicely the retina attached. So break lock, for example, if you find a break underneath the muzzle, you try to place one suture on either side. 7 mm width buckle, the role is posterior bite, you take 9 mm from ora. 9 mm width buckle, you take 11 mm from ora. And 10 mm width buckle, you take posterior bite 2 mm. So +2 is the tip. This is the patient who came, was having a chronic detachment, but unfortunately was going for MRI and some field only because someone has not seen complete fundus examination. And then when we looked actually detailed evaluation of the indirect ophthalmoscopy, there were multiple lattices in 3 quadrants, and then posterior lattice we have localized, and 287 buccal 3 quadrants have been put. And this is the scenario. And in intraop fellow eye, we could see that there is a localized GA examination because patient was not cooperative. So detailed evaluation revealed that she had actually another retinal detachment in the fellow eye. So what we learn from here is that accurate indirect ophthalmoscopy of retinal periphery of affected eye as well as the fellow eye is very crucial. Multiple breaks in multiple quadrants is not a contraindication. So in a patient where there is a PVD is not there and you have lesions all over, what you need to understand that it is the 4 quadrants and 8 sutures is all that is required for a buccal indicated or suitable retinal detachment. And this is a 31-year-old phakic who has a, you can see the break here. And when we localize, it was actually 8 mm from ora. And usually we are not doing this much more length buckles, but what we have done is when I localize the posterior margin, it was 8 mm. Still I have a material which can cover, that is 280, which is 10 mm buckle width, which can easily cover this by taking a 12 mm bite. And high myopes, it is not difficult to take a posterior bite at 12 mm, and you can see the result of the thing. So that's why, again, to stress, localization is the key. Accurate localization of posterior margin of the break is important. Understanding posterior vitreous detachment status, chronicity of the retinal detachment, subretinal PVR changes, whether it is a demarcation lines or intraretinal cyst, buccal will be the choice. So it's a 24-year-old phakic. You can see that the detachment was so shallow that only OCT could pick up. And here in this place, I actually went with the suspicious dialysis area was seen in superior nasal quadrant. So I took a 42 band, and then which was around 4 mm buccal width, it will give you around 6 mm coverage. So non-drainage, and you can see the retina attached. So no visible break, again, is not a contraindication. OCT can sometimes tell you whether there is a shallow detachment and also extent of detachment. Link of view can help you to identify the suspicious causative break, which will be as per the gravity in the superior portion of the detachment. When you have a lot of thinning, scleral thinning, which was noted here, what we have seen is this break was only 3 mm from vora. And again, I could not take any sutures in this area because such extreme scleral thinning, but I didn't wanted to go inside. And then we have actually just placed the buckle over a 42 band over that, taking one mattress suture, and then drained because there was significant fluid, and you can see an excellent anatomical results. So, so careful suturing should be done in whenever you have thinning. So sutures are better than the tunnels in this area. So I'll just show just a small brief steps of scleral buckling. So this is a patient who came with both eyes retinal detachment, and you can see that temporal detachment with multiple lattices were there. And so the surgery will be like where you do conjunctival peritomy, extreme and peritomy as well as the closure. Both are very, very important because we are leaving a foreign body for lifetime. So meticulous suture and adequate clear, sorry.
Doctor, 1 minute more.
Yeah.
Yeah. So after tagging and everything, so it's you localize always. Even if I have done 1,000 buckles, I will always localize so that you are actually, as I said, it is a designer surgery where you want to approximately place. So you place the thing, and this is something where once you place the thing, the Johnson bud is very crucial to make the thing flatten so that you take sutures appropriately. And all these needles has to be parallel to the scleral surface so that you can actually no inadvertent perforation will not happen. So this is how you place sutures. And then once you place the sutures, and then the next steps will be you make tunnels in other quadrants where it is required. If there are any lattices and all, I do put belt buckle in other quadrants also. And then you place the buckle. In this patient, we needed to put 2 quadrants. So the drainage always prefer the least vascular locations like near the rectus muscle so that as I said, uncomplicated SRF drainage can be done. You can do with 26 gauge needle just having bevel down. And then here, after conjunctival closure is also very important, where you try to close with episcleral blight in the middle and try to close it. 1 second. Last time. So this is how it was the post-op, and then other eye also followed the similar suit, and then this is how the other eye behaved. So this is some surgery where you can expect, even with a beginner, it will be more than 90% success rate. And even with the expertise, with over the time, you can always say that more than 98% success rate. Yeah. Thank you.
Thank you so much, ma'am. Always such a pleasure learning scleral buckle from you. I just had one question, ma'am. Do you prefer doing an encircling band in all cases in addition to the segmental buckle, or in some cases you would prefer just doing a segmental buckle alone? And what would the indications be for that?
So if I see any lattices in the attached retina, so I do prefer something like an encyclical band also as an investment, just to support the vitreous base and everything. But if you have a lot of scleral thinning in the other areas and you really don't have any pathology, then just segmental buckle alone should be fine. And as I said, with your time, the way you indent and the way you tighten, so we can also be, like refractive surgeons where they measure their refractive error for toric IOL. So we should also measure our refractive power, how much we are coming with our indent. So mine usually between 1.5 to 2 diopters when I do the buckle. So I have seen buckles going up to 16 diopters and 18 diopters because the amount of indent. So I think one should monitor the outcomes and make sure that you don't unnecessarily, tighten the buckle.
Thank you so much, ma'am. Any
Ma'am,
questions?
I have a very basic question. We have all learned Scleral buckle from you. We are very grateful for that, passing on that art. But if you know the PRO study or and all, even though the single surgery as anatomical success is highest with Scleral buckle, over the years we are not doing enough buckles. We are more gravitating towards vitrectomy or a combined surgery. So, what are the top three indications where you will definitely do a buckle? And if you can summarize the steps in a minute, it would be great for to encapsulate in just a minute if you want, if you can.
So actually, I chosen this even though it's a quintessential buckle. So we can talk about 3 hours also, 4 hours also. I chosen this presentation to just show the scenario. They were all actually the perfect scenario of the buckle. I would say that young patients, phakic patients, where you don't have any posterior vitreous detachment, right? And even multiple lattices, multiple lattice-like holes. Then, or if you have a old detachment, chronic retinal detachment, where you have subretinal gliotic bands, intraretinal cyst, subretinal PVR changes, I would say, and then high myopes with these kind of particular lesions, I would say that the buckle should be the choice and no other surgery. And buckles have reduced only because of the lack of art going in that direction. But otherwise, buckle will be always there. And buckle is something, anyone who knows buckle and vitrectomy, they know how they'll be always very happy to do buckle in a case which is suitable for buckle. So I think the decision making that this case is suitable for buckle, this case is not suitable for buckle, I think that is the first important. And even if buckle fails, right, that those cases are much more easier to manage by vitrectomy in that whatever the window period.
Dr. Naresh, would you want to add anything?
Yeah, no, I agree. I think buckle is an art, is a very good surgery, and everyone should be comfortable. I think we can blame on the better fluidics, better visualization systems. So instrumentation has improved. So that's why I think the buckle has come down. But still, I think in all the institutes, still buckle is being done. So there is no way that a new consultant or any fellow should say that I don't know buckle. I think if you know good indirect ophthalmoscopy, you can do good buccal surgery. The problem is the patients don't get admitted earlier. And when you ask the fellow to localize on the table, they struggle. Because by the time they tag the muscles, the cornea becomes a little hazy. The orientation of the globe also changes. So what I advise is that my fellow should see the patient before the patient is given block. So when the view is good, then they can localize it better, and then the surgical steps will be easier. Otherwise, they struggle to localize only. And by the time the consultants get irritated, then it takes over, and then so that learning gets affected. So the patient comes early morning. So before giving block, they should try to see the patient and try to localize there. And the other thing is the parallax. In the OPD, they always say, sir, this breaks looks very posterior. They don't realize where it is going to fall. So with practice, what they feel it is posterior, actually it's buckleable. So that also it's a art. I think good indirect ophthalmoscopy is the crux of the situation. I think with the optos coming and the OCT coming, 78 skills also come down. Indirect ophthalmoscopy skills also are coming down.
Dr. Hemant, a word?
No, I think what she has shown elegantly what is the conventional buckle. I mean, there would be a lot of other speakers who talk slightly differently, but that's a regular conventional buckle. I always keep the Amsler chart on the, put onto the wall when I do my surgery. So I know exactly which is the break that we need to look at. And as I agree, indirect ophthalmoscopy is what is the key to success, proper indirect ophthalmoscopy. Because if you miss breaks, if you have something else, that's where all the problems come. So a good indirect ophthalmoscopy is essential for everything.
Sir, I think if Dr. Rajiv Muni is there, I would
Yes.
like take his comment on pneumatic retinopexy because he is the exponent of it. Whether scleral buckle is as good as pneumatic retinopexy, or there are reservations on either of the procedures. Just if he can pitch in, if he's there.
Yes, he's there.
Hi, everyone. Good morning. I'm in New York today, and I hope you guys are all doing well. Thank you for inviting me to come today. My view is that vitrectomy is an elegant surgical technique, and instrumentation has been so refined, and all the cut rates and high speeds, but it's the most crude way of fixing a detachment. In fact, I think the most elegant approaches are scleral buckle and pneumatic retinopexy because they focus on the underlying principle of simply closing the break, as Hemant was just mentioning, that indirect ophthalmoscopy, finding the break, closing the break, and treating the break. That this is the underlying concept of retinal detachment repair, and if we can do that and not do too much, our outcomes will be the best. That's what I've learned in my short time as a retina specialist. So I like, I always tell people if I had an inferior break, let's say between 330 or let's say below 4 and 8, I would probably want a segmental scleral buckle or a radial sponge or something, assuming it was a single break detachment. And if I had anything above that, I would want a pneumatic because I know I would be very compliant and I would follow all the instructions and be conscientious with the treatment, and I believe that is what I would want in my own eye. So that's what I should recommend for any patient.
Thank you,
Thank
sir.
you.